And we let everybody in, Rafa?
Yeah, you can start.
Okay, I wasn't sure how many people were gonna come in from the waiting room. Hey, everybody. We have a lot of CPS team members here today. I'm Andrew. I haven't facilitated in a while, but it's good to see everybody. And we have another residency morning report today. So I'm just gonna pass off the mic to Ravi here.
Thank you, Andrew. Welcome everybody to CPS IMG VMR extra special edition on Saturday. And it's my delight to have Washington State University at Everett Internal Medicine Residency Program being represented here. We have Dr. Yang, who's pretty famous on Twitter and part of the MedEd TWAC team. I'm going to ask her to unmute her mic and introduce herself, and then we have residents from the program, Nikhila and Sujan. And I think we also have Sylvia, if you're able to, after Dr. Yang, to unmute your mics and also introduce yourselves. But I'll start with Dr. Yang.
Hi, everyone. Good to see you all. And thanks so much to the clinical problem solvers for having our residency on board here. A quick brief intro about me. I was born in China, but grew up in sort of the East Coast, been up and down the East Coast for a lot of my training, was at Emory for college and med school, couples matched to primary care at Yale. Was there for a chief resident year and a medical education fellowship, was involved with the primary care residency there for 2 years, and then switched coasts to the West Coast, moved over to Washington State about 2 years ago, was initially a hospitalist over at the University of Washington, and then joined a relatively new internal medicine program in Everett, which is about 40 minutes north of Seattle, called the Washington State University Internal Medicine Residency Program at Everett, which is where I had the pleasure of meeting and working with doctors Nikhila Pale and Sujan Badal.
Nikhila and Sujan, go ahead.
Yeah, thank you so much for having us. So just a little bit about myself. I was born in India, but I grew up and was raised in Toronto, Canada. I did end up going back to India for medical school, and then applied for residency pretty broadly as an international medical graduate, and have matched here. And I'm very, very happy that I matched here.
Right, and hey guys, my name is Sujan Badal. I was born and raised in Nepal, but I did my schooling here, my undergrad medical school at the University of Minnesota, and then applied pretty broadly as well. Did want to kind of move away to the coast side. Really love the Pacific Northwest here, so matched here, and I've been really liking the program so far.
Awesome. And if Sylvia is able to unmute the mic and also introduce herself.
Hi, I'm Sylvia, and I don't think I've actually ever talked in one of these meetings. I usually just sit in and listen to try to keep a fresh mind. I'm in between finishing school and studying for step 2.
Okay, great. And I think Nikhila and Sujan, you have a case for us today, so I guess we'll get started with the case if we can bring up the whiteboard.
All right, so I can start off. So we have a 38-year-old male who presented with a chief complaint of abdominal pain and yellowing of the sclera. Would you like me to pause here or keep going as far as past medical history and stuff like that?
Yeah, I think we can stop there. This is a great chief complaint and a little bit of the HPI, but I'm gonna ask my good friend Andrew, what do you think when you have a young person with abdominal pain and yellow sclera? What comes to mind?
Yeah, sure. I think that points pretty directly to the HPB system kind of off the bat. And of course, other causes of yellow sclera like indirect hyperbilirubinemia from hemolysis, but I mean, the first thing that comes to mind is I'm already wondering kind of what's going on in the HPB system in this patient, and also like who is this patient? This brand new presentation, or is this someone with cirrhosis for a very long time?
Yeah, definitely. The hepatobiliary system is definitely key, is front and center in this presentation. But I'm going to ask Dr. Yang, when you hear this complaint, Dr. Yang is an incredible teacher and definitely could give us some insight into what's going on with this patient.
Well, thanks so much. Yeah, I think some of the pointers that you all mentioned in terms of thinking about the epidemiology of this patient, what is their age, and then sort of the tempo of onset of the symptoms is important. So is this a completely new acute issue, or has this person had potentially some underlying chronic issue with their liver or with their biliary tract, and now this is some worsening? I think it's great to think about how to tease out, and then getting a sense of, you know, what potential exposures there might have been, I think are all important to find out more about in the history.
Absolutely, absolutely. And what I always learn from a lot of our great colleagues here on CPS is, before we even get underway with trying to figure out where exactly is the problem, is there a life-threatening cause of this? Is there possibly acute liver failure? Somebody had mentioned. Is there, as Andrew mentioned, hemolysis, or is there cholangitis? So a couple of things to think about before we really get underway to sell or figure out what the issue is at hand. I'm going to ask Nikhil and Sujan to continue with the next aliquot.
So this patient has no past medical history, and kind of coming into kind of the HPI. So he had noticed that he had abdominal pain starting about a week ago. It was localized to the epigastric region, and it was non-radiating. His spouse and himself also noted that there was yellowing of the sclera. He denied any shortness of breath, chest pain, nausea, vomiting, any urinary symptoms. On presentation to the ED, he did also endorse some weakness in his extremities, as well as fatigue and headache. And that's kind of all we got. There was really nothing else that he was complaining of other than this abdominal pain and yellowing of the sclera, and now some weakness and fatigue.
So he'd never had anything like this before, it sounds like. No, okay, interesting.
What comes to mind, Andrew?
Yeah. You know, of course, this could always be the initial presentation of something that's chronic, but of course, hearing that this is initial presentation of something that's never happened before makes me think that this is more of an acute process. Yeah, I'm just gonna read off the whiteboard here. Epigastric, you know, I try not to read into localization of abdominal anatomy early on, kind of before I get more information, because I know localization by anatomy isn't exactly perfect. Let's see, the weakness and fatigue and headache, again, very non-specific as well. I'm very curious for more like objective data if the past medical, and he also I definitely want to clarify ingestions too, like what medicines is this person on that could be causing potential injury. And then on top of that, you also want to make sure you're not missing stuff like herbal ingestions, things that you don't pick up from behind the counter at a pharmacy, to make sure we're not missing something that can cause like DILI, for example. But if that's really the only past medical stuff that's going to be relevant here, he was a healthy person, then I'm kind of ready for more physical exam, see how sick he is, and then also get some just very basic labs.
Yeah, so just a little bit more information. He reported that he does not take any prescribed medication, did not tell us that he took really any medication at all. Some social, family, and surgical history. He was born and raised in Mexico, moved to America about 10 years ago with no history of recent travel. He only has one partner, his wife, and he has no really family history of any autoimmune disease or any other significant medical conditions, and no notable surgical history. No alcohol use as well.
So that's quite important there. As Andrew had mentioned, any toxic ingestions, alcoholism, any travel history, that's pretty important to also highlight there. But I'm going to ask Dr. Yang, what would you, with this new information, what would you think at this point?
So this patient I think is somewhat different from a lot of patients where they don't have too much medical history or medication, so a fairly blank slate, and initially doesn't seem like has had any recent exposures or ingestions. I think the born and raised in Mexico, but has been in the States for quite some time can be helpful, certainly because this sounds like more of an acute process. Maybe that sort of being originally from Mexico is not playing too much of a role, but I think if this were maybe more of a chronic process, or if they had traveled more recently, then that may, make us want to broaden our differential to endemic issues, from wherever they recently traveled.
Yeah, definitely. I think at this point, what's common in the US, or if I would highlight one diagnosis at least, would be common bile duct stones. It could explain the abdominal pain, but just like Andrew mentioned, you want to localize this early, and it could be a red herring. So at this point, a couple of things come to mind. Viral causes, definitely. Also, I think common bile duct stones would also be something that we would entertain. Any other thoughts, Andrew, before we move on to the next aliquot?
No, just I feel like we're probably gonna see some interesting labs, so I'll hold some thoughts until then.
Yeah, one lab that I'm kind of interested in and anticipating, when you have jaundice, you're probably guessing a bilirubin at least greater than 6. So I think to have scleral icterus is about 4. In the nails, probably 2, if I remember, but greater than 6. That's a very high bilirubin that we're going to anticipate. Back to you, Nikhil and Sajan.
I'll go with the physical exam quickly. So his temperature was 98.6 on admission. Heart rate was 87, blood pressure of 132/75, a respiratory rate of 16, and he was satting 96% on room air. On examination itself, not in any acute distress. He has a otherwise healthy appearing gentleman. For his head and neck throat examination, he did have sclera icterus bilaterally. I would say a mild, it was mild. Otherwise, no significant findings on other head and neck examination. Cardiovascular exam was unremarkable as well. Regular rhythm rhythm. There was no murmurs. His pulses were intact distally. Lung exam was unremarkable. On abdominal examination, he did have kind of localized mild epigastric tenderness to palpation. There was no other rebound guarding, no other tenderness anywhere else. He did have bowel sounds that were present. And neuro-wise, completely normal neurological examination. He did not have any asterixis. He did not have any other kind of tremors. And the skin examination also was pretty unremarkable. Other than I forgot to mention, he did have some yellowing of under his tongue, actually. Some yellowing of under his tongue, but otherwise the rest of the skin exam was completely unremarkable.
Yeah, even though in real life, we wouldn't put a lot of weight into the epigastric localization, I will just say for like clinical reasoning, like board exam purposes, if we want to call that kind of like pancreatic pain that's causing the epigastric tenderness, and we want to link that to hyperbilirubinemia. I mean, acute pancreatitis can cause edema and compression of the biliary system and lead to backup of bilirubin. More chronically, chronic pancreatitis can cause fibrosis and compression of the biliary system in that way too. Just little pearls there, but again, in real life, I don't think we're going to put a ton of weight on that. I'm still very curious for the labs too in initial imaging. I'm hoping we're going to get a right upper quadrant ultrasound or a CT abdomen.
Yeah, I just want to echo what Andrew said. With that pattern of abdominal pain, pancreatitis does come to mind. And it doesn't always necessarily follow the rule that you're going to have a band-like pain around the abdomen to the back. It doesn't always go to the back, and which is commonly depicted in many different clinical vignettes of this presentation. Another thing that comes to mind, hepatic inflammation can be very painful. So acute hepatic congestion, Hepatitis can be very painful, and it's almost close in proximity to the epigastrium. If you get hepatomegaly, that can be very painful as well as you stretch Glisson's capsule. So that could also be something to consider. But what I'm also not seeing here is any stigmata of chronic liver disease or cirrhosis. So this, as everybody astutely mentioned, is an acute process. So again, things coming to mind, you'd have to think of viruses, you have to think about biliary tract disease, namely stones. There could also be other phenomena. There's patients epidemiologically in the age range for some of the rarer sort of biliary diseases that you could get. So we would have to consider some of those as well. But Dr. Yang, any input on what we're seeing so far?
No, I think y'all are spot on in terms of, there's some etiology that's causing what sounds like hyperbilirubinemia. I think folks are wanting to get some labs to try to clarify, is this all direct or is there some indirect? Could there be some etiology of hemolysis? And if there is some sort of cholestatic potential pattern to the liver studies, could there be a source of obstruction, whether that's in the biliary tract itself or more distally, an issue with the pancreas or within the liver parenchyma, some other sort of source of inflammation.
Okay, great. Back to you, Nikhila and Sujan, next aliquot.
All right, so I am gonna give you guys some pertinent labs, and Sujan can add in on any normal labs that he has as well. So we got a UA, which showed that there was moderate bilirubin. His CMP was pertinent for an ALT greater than 3,300, AST of 1338, ALK phosp of 109, and a T-Billy of 6.3. Lipase was normal at 43. His PT was elevated at 15.7 and INR of 1.3. His CK was 328. CBC with diff was completely normal. Hepatitis panel A, B, and C were non-reactive. We got an acetaminophen level, which was normal. And the ultrasound of the abdomen showed normal liver with normal size and an echo texture of the liver as well.
Wow, some remarkable labs there. What do you want to take a first stab at it, Andrew?
Yeah, for sure. I'm very primed to discuss this. I just worked on a transaminosis schema the other day in Approach. So really what I'm getting out of this is a severely elevated, I don't see the ALT, but I think it was 3,000, right? Something on that order. So
ALT, yep, greater than 3,300.
Greater than 3,000. So yeah, what this is a very severe transaminosis, I think out of proportion to a cholestatic lab picture. And you can calculate this R factor, which I don't know the equation to like objectively quantify that, but it seems like it's a severe transaminosis. And the differential on that from a post from Dr. Tapper on Twitter, this was a while ago now. I guess he was part of a study that looked at this. Acute CBD obstruction is something that's frequently not thought about by early learners. So I'm glad that we got the right upper quadrant ultrasound, because if you have acute CBD obstruction or biliary obstruction, the first thing you're going to see is a severe elevation in the transaminases. But of course, if we don't see that on the ultrasound and the liver tests get better, then maybe it just passed and that's that. The other thing is ischemic hepatitis and congestive hepatopathy. The definitions of that are kind of specific, but basically I'm thinking, like, is this person severely hypotensive or are they severely hypotensive? I don't really think we're seeing that sort of signature here. And we're also not seeing like a heart failure backup here, like no crackles on exam, no hypoxemia. And the last thing is drug-induced liver injury, and allegedly there's none of that on the med history, unless if we circle back to that later. So the other things we want to think about after that are infections. So hepatitis was already brought up in the chat, so I'm sure those are going to be coming as well. So those are the severe transaminosis etiologies you want to think about. Just like run-of-the-mill high AST, ALT though, the framework I developed is 3 Ps. So first is plumbing. Second is pregnancy. I'm not sure if this patient was actually a male or if you all switched the sex on the patient. And then third is parenchyma. I think 3 Ps is helpful because you won't forget the most common causes and the like life-threatening causes. So for the plumbing in the patient, you want to think about the CVD obstruction I brought up. So that's like the biliary plumbing. And then you want to think about the vessel plumbing going in and out of the liver. And that's going to be things like ischemic hepatitis and congestive hepatopathy. So you've already covered 2 of the big severe etiologies with that P. The second is pregnancy, which is often forgotten. So you have to think about like HELLP syndrome, fatty liver of pregnancy. And then parenchyma, you can think of in 3 different buckets: toxic ingestions, which again, we've touched on here. That doesn't seem to be the case. Infections is the second part of the parenchymal bucket. So hopefully we're going to get the hepatitis serologies, and there are a couple other infections. And then the third bucket is autoimmune disease. So that's going to be kind of like esoteric land. So basically to get to autoimmune hepatitis and autoimmune parenchymal disease, you kind of have to go through the infectious workup. You have to get your supplemental history. So just to summarize, the 3 Ps are plumbing, there's going to be biliary and vascular, pregnancy, and then parenchyma.
Great job there, Andrew. Great differential of elevated liver enzymes. So we're dealing with AST/ALT up into the thousands, and there's only a number of things that can cause that. So you astutely pointed out infections, ischemic injury, viruses could do that. But it's interesting that you mentioned a lot of people forget that acute biliary stone disease could cause obstruction and immediately could cause an upswing in the liver enzymes into such a high range. So commonly we don't associate that with that, but it can happen. Then the second thing is congestive hepatopathy can also cause liver enzymes up into the thousands. So this list of differentials that Andrew went through, something definitely to keep on your glass health notebook or Evernote. Anything else, Dr. Yang, you're thinking of regarding these liver enzymes?
Yeah, I think the 3 Ps is a really great framework, Andrew. I think for the plumbing aspect, I would also add sort of thinking about etiologies like Budd-Chiari or portal vein. Oftentimes, I think when we're getting the ultrasound, unless we specify and ask for a duplex, sometimes the radiology folks won't get that information. And so to really, look at the vasculature, you want to make sure when you're ordering the study to also include a Doppler to look at the hepatic vasculature as well.
What's interesting, if you go through the pattern of the liver enzymes, what if I had to do a deeper dive into that? The ALP is very low. Here you see AST/ALT greater than the ALP. And referring to the R value that Andrew had mentioned, I used to use that for a majority of these liver enzymes, but if you look at the guidelines, they do suggest to use it for drug-induced liver injury. So, but if we do apply the R value to this would mean this would be primarily hepatocellular versus a cholestatic picture, so more of a hepatocellular injury. So the ALP is very high. What if the ALP is much, much higher than AST/ALT? So we could be dealing with a cholangitic picture, obstructive picture. There could be common bile duct stones involved, or they could also be space-occupying lesions in the liver parenchyma. So things like granulomatous disease or tumors, malignancy, metastatic processes to the liver could manifest with ALP being greater than AST/ALT. But here we have a predominantly elevated AST/ALT, and that's pointing to the differential that Andrew had indicated. So great job. Nikhila and Sujan, can we go on to the next aliquot? Or do you have one more aliquot before the final diagnosis?
So this patient actually had a multitude of tests and workup and everything possible done. So I'll let Sujan kind of tell you those.
Okay, great.
All right, so I'll fill in some of the gaps that I see here. So his direct bilirubin was 5.3. And then the EKG, chest X-ray did not show any significant findings there. He had some additional labs that included iron panel with iron of 208, transferrin of 201, % SAT of 73.9. He had a ferritin of 4,465. He had autoimmune panel that included anti-mitochondrial and anti-smooth muscle testing that were both negative. His ANA profile was also negative. He had HIV testing, which was negative. He had HSV1 antibody IgG, which was positive. HSV2 was negative. HSV2 IgM was positive. He had an EBV and CMV, both of which had IgG positive, IgM negative. His ammonia level was 34. And then we also did a liver biopsy that was negative for IHC genetic screen for hemochromatosis.
And then at this point, we got a bunch of specialists on board.
Are you going to stop right there?
Yeah, so I guess to all of the tests that Sujan mentioned, these were all recommendations by the GI and infectious disease doctors as well. And in the meantime, the patient was also getting a cyclovir treatment as well for those positive antibodies that he had.
Very interesting. I'm going to flip the switch and ask Dr. Yang to comment. What would she think at this point with this data?
Yeah, so I think he had a pretty extensive evaluation looking at some of those etiologies that would lead to such severe AST, ALT elevations. I think the HSV serologies are interesting. I think depending on institutions, sometimes people are using serologies. You can also consider doing PCR testing for things like HSV, EBV, CMV, potentially even VZV. As well, to get a sense of sort of how active those infections might be.
Yeah, I'm not sure. You named a couple of like viruses, EBV, CMV. They can have an affinity for causing liver injury. To this degree, possibly HSV, or it just could be a red herring. It could be a simultaneous infection that we've caught and something that the team was treating. In regards to the ferritin, which was interesting, everybody sort of probably made the direct sort of relationship with the liver when they saw that elevated ferritin. But as we all know, ferritin is acute phase reactant. So it doesn't necessarily mean there's hemochromatosis. There could be a number of different things. Ferritin can elevate in HLH, in adult onset Still's disease, in histoplasmosis, other granulomatous disease. So it can be non-specific, but we do tend to look for a much higher hyperferritinemia. But that was something that was, I guess, picked up by the chat. And I immediately started thinking, could this be hemochromatosis? But I'm not seeing any of the sign of iron overload or any risk for iron overload in this patient. But it is a diagnosis to consider in the grand scheme of things of liver injury. Andrew, what do you think? What does this data do for you?
Yeah, just commenting on the hemochromatosis. Yeah, a genuine question is I'm not sure if there's kind of like an acute hepatitis version presentation of hemochromatosis. In my head, it's more of like somebody with like joint pain, like diabetes, kind of like more insidious presentation. So yeah, I'm sort of getting the flavor that if that's true, that there's not that variant out there, that this ferritin's probably just secondary to something. And yeah, I have HSV hepatitis on my list of infections that can cause acute transaminosis. I usually think of a rash being a nice clue for that in terms of getting your way to that diagnosis. Clearly, this person doesn't have that rash. But yeah, to this degree, I can't recall off the top of my head if it can be this severe, but it is on my list. It's been mentioned to me in the past.
Yeah, that's interesting. It is in the differential, but I have not seen or read a case with HSV hepatitis to this degree. So you can never say never, but we'll see with the next aliquot when Nikhil and Sajal tell us or show to us. Go ahead.
I'd also add maybe in terms of somebody who's 30 and otherwise healthy, some of these viral hepatitis, I also think of maybe being more severe in people who are immunocompromised, particularly things like CMV.
Yeah, I think at that point, the treatment with acyclovir was just because we didn't have a better answer, and we were like, maybe it's this. But after a lot of prodding and asking the patient, he did say that he was drinking green tea, this fat burner green tea, for the last
I
month.
knew it. I knew you were gonna circle back.
Yeah, but it did take asking him a couple of times for him to remember that this was something new that he was drinking. It was like a weird fat burner green tea extract thing.
Yeah, kombucha is another one I've seen, not in person, but it's one I've been learning about because a co-resident of mine, he's going to GI, he's very into ingestions. But yeah, apparently drinking a lot of kombucha, which is on the tea spectrum, I guess somewhere. I don't drink either of these drinks, I don't know, but you can have very fulminant liver failure from kombucha as well. Wow, that's crazy. And I feel like it always plays out this way where it's after all this is done that you get the information.
Yeah, that's why I kind of also mentioned be careful with this HSV finding as well, because it seems like a plausible answer, but it may just be something traveling together that we incidentally found. And like you mentioned, we didn't see the rash. Maybe the rash happened before. We're not quite sure. But again, something I will learn from this case to be persistent and keep asking. I think kudos to your team for being persistent and asking about ingestions. Which the patient may not have disclosed, and you could have gone down a deep rabbit hole with this HSV. And by treating it, probably the patient's liver enzymes probably wouldn't even come down. They may have just come down by themselves. But yeah, Dr. Yang, any other input on this case? It's very interesting.
Yeah, no, I think there was in talking with Sujan and Nikila when they were taking care of this patient, a lot of discussion in the background of sort of how much was the HSV really at play as well. But yeah, I think the only other thing I would add in terms of potential teaching points of infectious etiology, since we are talking about global virtual morning report, is, if this patient had been coming from another country, perhaps somewhere like India, important to think about another hepatitis that might not be as prevalent here in the US, which would be hepatitis E, which can also cause sort of a more acute liver injury, possible acute liver failure etiology.
Great point about that. And also there's a multitude of herbal medicines that are taken in India, taken in South and Central America, which have a number of ramifications, one of which is liver injury. So always good to get that history, and as I'm learning here, to go back and re-encounter the patient and ask for, again, any herbal medications or green tea. Was it a particular kind of green tea? There's quite a bit of green tea that's ingested or taken, consumed around the world. Is it some special green tea that may have had some ingredient that could have caused this, or is it just green tea across the board?
So it was so I have a picture of the thing, because his wife sent us the photograph of the green tea extract package that he was taking. So it just says green tea extra strength fat burner extract, and the patient was taking it heavily, at least for a month before he had come in. I think if you Google kind of green tea fat burner extract, the first photograph you'll see will be that the packaging of that one.
So it may be that he was taking it heavily. When you mean heavily, several times a day, that could have, over the span of a month, caused this extreme presentation. Interesting. Great to know. Andrew, any final reflections of the case before we move on to learning about this incredible program?
No, just I mean, even here in the US, I mean, I forget how the law exactly works, but things in the realm of supplements that are in pharmacies or not sold in pharmacies, more just from like shops you can find online, there's actually no law, unless if the law changed recently, where you need to list all the ingredients in your supplement that you're selling. So there are a lot of patients that are using like these wellness companies that are just in the middle of nowhere, like backyard America, where people are just kind of like making their own remedies and you have no idea what's inside of it. And that people die from that, unfortunately. So Yeah, you just have to be wary, because even here in the States, the supplement industry is not well regulated at all. I'll try and find the law name while we talk about the program.
Awesome,
I-
awesome.
I do want
Go
to
ahead.
add that this patient's recovery was quite remarkable. I mean, he followed up in clinic with us a couple of months later, I think 3 months later, and his AST and ALT came down to 22 and 31. So
This must have been an alarming wake-up call for the patient.
Yes, definitely. And obviously they're staying away from any kind of green tea or any supplements from now on. We did kind of also report this to the Washington Poison Control and discuss the case with them as well. And then otherwise, we're kind of happy to see that he had a complete recovery from all of this.
I just want to say a marvelous case, and Nikhil and Sujan, you did a wonderful job in presenting this case. It was so expertly presented. I really appreciate you bringing this, preparing before this and presenting it to us today. So a job well done. I'm going to ask Dr. Yang to tell us a bit about your program and life around Everett near Seattle, Washington State. And then I'll have Nikhil and Sujan sort of also weigh in on how what they think about their program and how is life in their program.
Absolutely. Yeah. So I consider myself actually a newbie to the program. Nikhil and Sujan have actually known this program a little bit longer than I have. But so this residency program is fairly new. We have 2 classes currently, so a PGY2 class and a PGY1 class. We are a community-based but university-affiliated program. So the university that we're affiliated with is Washington State University, which is based out of Spokane, so in Eastern Washington. But the medical school has multiple different locations and sites around Washington State. The Everett location, like I mentioned, is I'd say like a mid-sized city, about 40 minutes north of Seattle. And the program, I think, has a fairly specific mission in that we are hoping to train physicians to serve both potentially rural or underserved populations here in Washington and the Pacific Northwest. And as a result of that, there are a couple of unique features of this program. I think one, we have a sort of holistic review process in terms of when we're looking at applicants, but 2, really looking for folks who have experience or have a passion for serving folks in rural underserved populations, are interested in outreach, and are interested in a program where there's a emphasis more on outpatient medicine. So I think in terms of ambulatory time, our program, if you compare it to a lot of other internal medicine programs, has a larger proportion of ambulatory time compared to most other programs. That being said, I think there's still enough exposure to inpatient medicine and subspecialty rotations, but I think the way that our ambulatory clinic is structured in particular makes it so that people have a little bit more continuity with their own patient panel. And gets to see a little bit more of sort of what a functional clinic space can look like.
Oh, great. And they all get to train with the fabulous Dr. Yang. So that's another advantage that your program has. Nikhila, anything about the program you'd like to say?
we were just gonna type something in the chat, but we did want to say that me and Sujan are the inaugural class, and we found that our group of residents and our leadership has been extremely supportive of the transition, not having seniors, and then our faculty acting as our technically seniors, and they've been extremely supportive of the change and our feedback every time we faced a difficulty or any change that we wanted to see in our program. They were extremely receptive. So I think that is probably our most favorite thing about this program, is just how supportive our program has been.
Yeah, and I completely agree. And just adding to that, just all the opportunities that we as a first year class had in kind of shaping the program and kind of making these changes have been kind of really like great opportunity and experience for us. And again, the leadership have been very receptive to kind of all our suggestions and change, and we have continued to grow throughout our first year. Now we have a second year class, and feel like things have only gone for the better. So really excited about the changes to come, as well as how we have gotten so far as well.
Wow, that's so incredibly exciting to see that you're the first class and you're setting the tone, the climate, the environment of the program. It's exciting to also have another program be welcome into the family of programs across the nation. So incredible. Your community must be very lucky to have you there, and also to have Dr. Yang move over to facilitate the learning and bringing a lot of vast experience to the program. I'm going to ask Amanda. She has a question. If you're able to mute your mic and share your question.
I have a question for Nikita and Sujan. So what do you do for fun in your program?
Well, specifically in our program, we have get-togethers. Our program sometimes sets up get-togethers, either whether that's in the hospital or outside the hospital. Individually, I think our class is composed of a lot of people that are married and have kids, or people like me who are unmarried and don't have kids. And as far as things to do in Everett, and maybe Sujan can add to this, there are a lot of little cafes and like little restaurants here and there. We're beside the waterfront, which is really nice. Yeah, and then that's all I've been doing. I've spent a lot of time in the hospital, so I can't say that there is other things that I've been doing.
Yeah, so I mean, at least from the program part, there's a lot of kind of resident run get-togethers. We just had a very nice Thanksgiving potluck yesterday with all the residents, and everyone came in and brought stuff, and we had a really good kind of lunchtime together. And then we try to kind of meet outside the program as much as we can as well. But again, there is people having families and not always being able to do that. Other than that, in Everett itself, there's a lot of outdoor things to do. If you are kind of in the whole state of Washington, I would say, if you are an outdoorsy person, you like to hike, you like to go on, go like see the mountains, go see the national parks. There's a lot of opportunities to do that. And at least in my short time here, I've only been able to go to Mount Rainier kind of National Park, and it's very beautiful. It's if you have time, you can be there for several days and still you won't be able to see everything. But there's a lot to do if you are outdoors kind of person, for sure.
I just want to add, Canada is close by the Canadian border, so you can even take trips into Vancouver, the west coast of Canada, which is also that whole region is just so beautiful. And I want to also ask Deborah, she has a question too, if you would like to share your question.
Yeah, I think they kind of answer what I was. Thank you for the case. I forgot to say it was a really good one. Thank you for being with us. I think they already answered. I was asking about the program and they talk a lot for us. I think Emina has another question. Do you want to talk?
Yeah, thank you, Deborah. It's hard to follow Amanda's fun question though. But my question was for Dr. Yang. Dr. Yang, you mentioned something about community outreach. I was wondering what some of the community outreach opportunities are for interns.
Yeah, great question. So one big feature of our program is that we have a partnership with an organization called Mercy Watch and several of the other community-based outreach programs for people who are not housed. So for interns in particular, and upper levels as well, there's sort of different experiences during the year where we work and partner with these organizations to provide medical care on site, either at a local church where there are sort of respite offerings or free meals during the week, where we arrive with the resident who's on an ambulatory rotation and see those patients for medical care, try to connect them in with primary care. Oftentimes, if someone we're meeting on the street does not have a primary care provider, we actually call our clinic, get them scheduled for a visit. And several of our continuity patients have actually been from those outreach activities who've been able to get plugged into care. And I think there are other sort of more planned activities in terms of one-off outreach events that are happening, whether that's like clothing drives, food donations, those sorts of activities. And then Nikhil and Sujan, I don't know if there were things that y'all did last year that I missed before joining.
Yeah, I did want to add, so that Mercy Watch program that we also have a medical truck or this van with all the medical equipment that we just drive around the streets of Everett, and we help whoever we can on the street, and it's been really great. They're very thankful. And something else also to add is starting from this year, so we are in the process of actually doing this, is going to a rural service, a rural rotation. So actually in 2 days, I'll be leaving to Ilwaco, which is about 4 hours away, where it's a very rural area as well. And we'll be working in a hospital over there as well.
That's actually very hard for me to hear. Thank you so much. And I believe that's very necessary in medicine. And thank you so much for the phenomenal piece. It was really nice to witness that.
Great. That's so great to hear that you're going into the communities, especially underserved remote communities, to deliver medical care. That's such a great initiative and part of your program to hear about. There was 1 or 2 questions. I guess one is a generic question. How would somebody's interested and they're on that side of the country, how would they apply to your program? And does your program accept IMGs?
Yes, we absolutely do accept IMGs. And then we're a part of the ERAS application. And so if you can find us, I could try to actually look up our program number, but yeah, you can apply through ERAS. If you have a particularly strong inclination to being in this geographic area, I know ERAS recently started the whole like geographic signaling and that sort of thing. And so that's something that you could indicate on your application if you're interested.
Just out of curiosity, what is the PGY1 class size that you recruit?
Yeah, I believe there's at least 14 categorical interns, and then there's usually 2 preliminary interns as well.
Clarifying that, I think 12 categorical and 4 prelims.
And since you're affiliated with University of Washington, I must assume that you probably go to do rotations at University of Washington campus site.
Oh yes, that is a little bit confusing because there's a University of Washington and Washington State University. They're both sort of state-based programs. So we are affiliated with Washington State University, and then locally in Everett, our clinic and some of our clinical rotations are based out of an organization called Providence.
Okay, very good. Any other questions?
I guess there was this question on if Dr. Ying could explain what is the best part of her job.
The best part of my job, I think, is just working with people who I think have a energy and passion for what they're doing. I think because we are a new program and also a fairly small program, I think everybody knows everyone, but the people who are joining are folks who are passionate about seeing a new program start, are really interested in sharing the creative ideas on how to make program better, how to sort of bring sort of a fresh energy to patient care, to education. And so I think from our residents to our clinic staff to our other core faculty, I think everybody sort of has this pioneering spirit, and that's been really, really fun to see.
Great. I think any other questions before we wind it down? Oh, we have Amna, you have another question? And then you've Banish. I think you have your hand up.
Thank you for this opportunity. I live in Seattle, Washington. I have a cold currently. Sorry for my voice. So I didn't heard about this program yet. I tried to look in the RAS and Explorer. I couldn't find it for now. I need to have the link. The other thing is, are you really accept all the IMGs? Because I'm already labeled to be an old IMG. I have an abundant experience in primary care, and then I cleared every exams and then waiting for opportunity. So I just want to know these two questions.
I can attest to that because I am an international medical graduate myself. So yes, our program does take IMGs, and we did leave a link in the chat box that you can see.
Thank you so much.
Thank you, Nikila, for putting that link in the chat box. Any other questions before we wrap it up?
Maybe one last question would be,
Sure.
In your opinion, what makes the program unique?
Yeah, I can take that. At least for me, it was kind of me choosing the program was firstly kind of the location was the big thing for me. But then the program itself, the uniqueness of it for me was that it was a new program, and how I would be able to kind of participate in not just kind of being a resident and learning kind of the clinical aspect and learning internal medicine program through my residency, but also being able to kind of participate in administrative aspects of it and able to shape the program and all the experiences I would get through that. And that has been the case so far. So that was the unique aspect for me about the program.
It was very exciting to hear about the new program. Always great to hear that new programs are being opened up across the country to serve a lot of our areas that are lacking primary care and access to primary care, also medical institutions and campuses and so on. So I really appreciate Dr. Yang for coming on and bringing your super residents, Nikila and Sujan. Fantastic case. Really appreciate you teaching us today about this patient and about your program. Rafa, back to you. Anything before we close up?
No, I just want to thank you, Dr. Ying, Dr. Nikita, Dr. Sujan, for coming. It was such an incredible session, and we're so thankful for you to be here. And I just hope everyone have a good day.
Right. Take care, everybody.
Thank you.
Thank you. Bye.
Thank you.